Good morning. Welcome here in Rong Zhai. Let me first introduce myself and then to try to explain why we are here today. My name is Giancarlo Comi. I'm a neurologist. I am the president of the European Charcot Foundation, which is a foundation for MS research, worldwide active. And at the same time, I am also the president of the scientific committee of the Prada Foundation, Human Brains. And I thought that it is very appropriate if I can start just to tell you something about this type of foundation. So the foundation is born in the mind of Miuccia Prada about 4 years ago. Miuccia Prada is a very curious woman. It's a long time that she is fully involved in art, exhibitions. And for those of you who will have the opportunity to come in Milan, please go and to visit Fondazione Prada because there are a fantastic exhibition there. But some years ago, Miuccia Prada got interested in the area of neurosciences. And the main reason she explained to me is that the human being is her or his brain. So if you want to understand human being, you have to first try to understand brain. And brain is really, in some way, also at the origin of the culture, at the origin of philosophy and everything. So I think that she was absolutely right in giving such a priority to the human brain. And human brain is something really unique, and what is incredibly curious, if you like, is that human brains is never similar one to another. There is always some, maybe subtle, but always absolutely relevant differences. That means that it offers such an incredible varieties of personalities. So if you want to understand human being, you must first understand the brain, how the brain functions. That's really the concept. And this is also the reason why we started the first activity of these human brains promoted by Prada Foundation was to have an exhibition in Venice about brain from the really very old times, from the prehistorical period till today and tomorrow. The exhibition was extremely successful. And then the second initiative was an initiative where we had a lot of events organized with the most important, let's say, expert in the area of brain function, from the biology to the neurophysiology, to the anatomy, to the philosophy. Then we organized a group of conversations where, again, two experts, again, internationally leaders in different areas of neurosciences, debated some key points, hot points in terms of brain function. And the last activity we organized was last year in Milan, and the activity was an activity that we defined preserving the brain. And what happened here today is in some way an extension of this activity. Why preserving the brain? Because we thought that there is an incredible increase in the frequency of neurodegenerative diseases. And now that the advances of science have in some way given the human being the possibility to survive longer, it is fundamental to align the brain survival to the body survival. Otherwise, we have a life that extends by 80, 90, 100 years, but we forget why we have to stay there. Because our brain doesn't follow, doesn't really accommodate with what happened in terms of physical functions. So we thought we should really try to convene the major experts in neurodegenerative diseases to try to understand what we need to do. And then it happened in Milan, it happened in last October, and about 60 scientists come together in Milan from everywhere, and they discuss quite a lot about neurodegenerative diseases. In association with this type of meeting, there was an exhibition that was organized in order to try to reproduce the journey of the treatment from the very initial phase of understanding the pathophysiology of the diseases to the discovery of potential therapeutic targets till the final availability of the pill in the pharmacy. And this was not for the expert, it was for everybody. Just to try to communicate to the entire community the complexity of discovery a new treatment, and then to try to explain why it was so difficult to have a treatment available for neurodegenerative diseases. Because what they have in common is that for no one of them we have available something that may really serve to modify the disease evolution. Multiple sclerosis, Alzheimer's disease, Parkinson's disease, ALS, Huntington disease. Unfortunately, no one of these treatments of these diseases have a definite treatment. That's a very important point. So human brain is a collaboration of a combination of incredible advanced institutes worldwide. I think if you look at the list here, you see that really all the major research institutes in neuroscience are present, from Karolinska to Boston, to New Haven, to UCSF, University College of London. I mean, really all the major institutes have collaborated to both to the exhibition and to the organization of the meeting. And here you see the list of these institutes. And we have the privilege to have here with us the one who represented China in this very, let's say, challenging type of activity. Many thanks again, Professor Shi, for giving such a fundamental contribution. I think that you will have the opportunity later in the day to go and to visit such an exhibition. You have to excuse, it's not really a top scientific, because we wanted really to have everything understandable from everybody. I think that the event in Milan was complemented by 12 other meetings that took place in different institutes in different parts of the world, again dedicated to different aspects of neurodegenerative diseases. So globally, 200 experts were involved in this activity in these 3 years. This is just again to give you an idea about, for example, we have in Tianjin Medical University one of these meetings in neuroimaging of dementia. So I think that the final lesson that we have in some way derived from these 3 years of activity are here a bit summarized. I don't want to go in detail in the interest of time, but essentially the message is that only if we work together, we may try to accelerate our process of discovery of a new therapy for neurodegenerative diseases. Working together is really fundamental. And what happened today here in Shanghai is an example of how relevant it is to work together. And please try to raise points, questions, because we are here just to facilitate the discussion. The second key message that I received from this 4 years of activity is that young people are fundamental. Young brains are the more productive ones. So we should pay a lot of attention to our young fellows because they are our richness, they are really our value, they are our power. So I think this is really a very positive message for the future. So I stop here, and I would like to ask now Professor Shi just to open the activities.
It is my great honor to sit with Professor Comi and his colleagues. It's a great honor for me to have the gathering here and to run the event. So Professor Comi just gave us a very detailed and clear introduction of the background and the rationale of this event. And our team is very honored to be involved. Professor Comi is a leader, worldwide leader in multiple sclerosis. And what's more important, he has done a lot in the education, in the popularize the science, and he has made a lot of contribution to the development of neuroimmunology in China. I'm also very grateful to Prada Shanghai. Thank you so much for providing this very elegant setting so that it's different from other conferences. It's a very intimate environment in which we can have a very close discussion. So Professor Shi, Professor Zheng Pei, so they have a lot of preparation work with Prada Shanghai and Prada Milan. So
device from 从 MS 开始到 NMO 到
So from the a lot of topics from multiple sclerosis and Alzheimer's disease to other neurodegeneration diseases and anatomy, physiology, we can cover a lot of topics in this event. We'd like to make this event a very unique one, and I look forward to a very successful event. Thank you.
Thank you so much, Fudong. Okay, let's start the activities, and we start with conveying with you some of recent advances in the area of multiple sclerosis. These are my disclosures. What I will try to do with you in the next half an hour is to try to review with you one of the most really important discoveries of the last year, that is the role of Epstein-Barr virus in multiple sclerosis. Then I will elaborate a bit about the pathophysiological mechanisms that are characterizing the disease in the different phases. Particularly, I will go a bit more in depth in the understanding the mechanism of disability progression in MS. A very short view about digital medicine, because this is another important ongoing revolution that will change quite a lot the way to operate in medicine, and of course at the end I will say something about treatments. So the Epstein-Barr virus is an extremely clever virus, because this is a virus living with a human being since incredibly large amount of time. Is a DNA virus. 95% of the people, independently from where you are living, is living together this virus. So extremely successful. Unfortunately, in some cases, this solid link is quite severely disturbed, and the virus is the cause of some very severe disorders, including gastric carcinoma, nasopharyngeal carcinoma, many different types of lymphomas. And it is also implicated in some inflammatory diseases like multiple sclerosis and lupus. So an incredible amount of roles for this virus. Well, the understanding of a key role of the virus MS was based on some epidemiological studies performed already more than 20 years ago. Just to be very, very simple, what has been emerged from these studies was that those people with a positive positivity for the test of antibody, anti-EBNA, one of the many different types of antibodies that are due to the presence of the virus, have a much higher risk of MS compared to those who are negative. If you look here, if we take as a reference those people with the EBV positivity, 95% of us, we will see that those who have negative or who are negative have an extremely low, close to zero possibility to have the disease. But the most interesting message from the immunological point of view is the second message. And the second message is that those people who became positive with an episode of infectious mononucleosis, which is one of the modalities. Usually the virus enters the body without any evidence. But in some patients, it may result in this infectious mononucleosis. And when it happens? Well, usually it happens at the age of 14, 15, 13, in the adolescent. Usually the first contact with the virus is much earlier than that. So the message here is that if you enter in the contact with the virus later in life, you have more risk to have such an infectious mononucleosis, and you have much more risk to be affected later by multiple sclerosis. So if you make a lot of estimation, it results clearly that the risk of MS is 40 times higher in patients with the mononucleosis compared to those who are negative. So it is clear that the virus has an incredible role to play here. But most of us, I said, have the body in contact with the virus and we are not affected by MS. That means that you need to have something else. We are discussing just early this morning about the fact these complex diseases have always a combination of environmental and genetic factors. And here you see that in these columns that if you have a given type of profile in terms of genetic, I don't want to go in details, but it has to do with the HLA system. If you have a given type of profile, then the risk of MS, if you had a mononucleosis, jump 20, 30 times higher. That means that you have to have some modulation of the risk based on genetic, but also based on other environmental factors. So for example, if you are less exposed to sun, you have much more risk to have MS. So it is clear that all the factors add each other just to reach the threshold that then may result in MS. It's a general lesson for all the neurological diseases. But what was really new last year was this paper from Alberto Scherio group. Well, this was one of the most clever epidemiological studies I had the opportunity to see. What this group did was they took the samples of the military forces from US, from about 60 million people who have been followed for many, many years. And they tried to examine in the serum the positivity for Epstein-Barr virus. And then they followed the patients and they wanted to see if those who had MS later they had some differences in terms of what happened before. And to make the story very, very short, is that they come up with a group of about 800 patients. 766 had the positivity for Epstein-Barr virus when they started to be examined, and then they later developed MS. But the most important point was that there was a group of 35 people who developed MS without having before a positivity. So these people were negative when they were first seen and examined, then they were followed, and then they got multiple sclerosis. Well, what happened to this population? Well, the first point is that almost all these patients, 34 out of 35, had to convert to positivity before to be affected by MS. So there was only one exception. That means that if you look at the evolution, you start as a negative at the test, then you became positive, that is the blue line, and after some years, which can be quite variable, can be a couple of years, but can be also 10 years, you are becoming affected by MS. But if you don't become first positive, you cannot become an MS person. So the presence of the virus is absolutely mandatory, so it is the key player in MS, which is really a very, very important point. And this is true because they also try to see if this was an exclusive aspect of the Epstein-Barr virus, or if other viruses did share the same behavior. And the answer is no. They took different viruses. For example, here I show the example of another virus that didn't absolutely change in terms of positivity before to be affected. So it is clear that is only this type of virus. And of course, that means that the virus is in the brain and has some activity to play there. There have been a lot of different pathological studies. Some of these studies have demonstrated the presence of the virus, particularly in the meninges, which is very interesting for many different aspects. Some other studies did not confirm such a presence, but they were a minority of studies. So as it is now, it is clear that the virus is there. What is not clear is which is the role of the virus. Is the virus there, and then because of the presence of the virus in the CNS, what happens is that we have some reaction of the immune system against the virus, and it's this reaction that is determining the disease and the cause of the attacks, or vice versa, is just the virus, the one that starts the process, inducing in some way an autoreactivity against neural antigens that they may result in the brain. There are some evidences that this can be the case because some of the antibodies against antigens of the virus share some peptides with the virus itself. So it is quite clear that there is such a possibility. Here we see some examples in terms of one of the antibody against the EBNA1. Very recently, another paper has come up with an evidence of a molecular mimicry with one of the antigens that is the glial ICAM. Without again to go too much in details, but this is really for sure a possibility. However, we still miss the definitive evidence that this is true. Still, we should take in consideration also the other alternative, that is the presence of the virus in the brain that is responsible of immune reactions that are, in any case, just only a reaction against the virus that reactivate during the different cycles of the life of the virus. This is still unknown, and what has, of course, a lot of relevance is that a lot of different initiatives have been promoted in order to try to contrast the virus. One possibility is, of course, vaccination. The other possibility is to try to destroy the virus using an anti-B cell, because the virus is living inside the B cells. So an anti-B cell therapy may have a strong impact. Other type of strategies could be here listed, like the ABNA1 inhibitors. But this is a new line of research that is now quite active, because this could be the real cure for the disease. So the disease then, and let's move to the second topic, is typically something very different from all the other neurodegenerative diseases, because the disease has at the beginning a phase which is characterized by wave of inflammation that enter the central nervous system, and these waves of the inflammation are due to some activity that is promoted at the periphery of the immune system, and then they enter, the activated cells enter the central nervous system and destroy the tissue because of the re-exposure to the pathogenic antigen. However, which is unique, is that after this acute series of attacks, patients enter at a variable time, entering a phase of progressive degeneration. And here, the pathophysiology changed completely. It doesn't matter if you block the penetration of new wave of inflammation, they are not really able to modify the course of the disease, because now what is driving the tissue destruction is something that happened inside the central nervous system. And the innate immune system, particularly microglia, perhaps with the contribution of astrocytes, monocytes, have a key role now. So here we have two different diseases, if you like. This was the view for a very long time. Of course, the age per se is a negative factor. The age may in some way contribute a lot to the process of neurodegeneration, and this is common to all the neurodegenerative diseases. We'll hear more in the other talks about this point. So the type of damage then take place inside the CNS can be variable combination of different mechanisms that are here listed, still not clear which one is the most important one. More recently, what seems to be very relevant is the presence of the so-called smoldering lesions. So these are lesions where we continue to see some ongoing inflammatory activity, mostly driven by microglia. Quite different from what happened in the acute phase. So then if we go back and then we think again of the separation between the relapsing phase of the disease and the progressive phase of the disease, well, what we know then is that in the relapsing phase of the disease, most of the tissue destruction is based on this wave of inflammation, and what is determining the damage are the attacks. And in fact, the attacks that occur in the early phase of the disease has a strong influence on the risk of long-term disability. This is the reason why today, as we will see, we treat aggressively in the early phase of the disease, because if we control the disease in the early phase, we can change the evolution. However, with the disease evolution, what happens is that we lose such an effect, and you see that attacks that occur after 10 years of disease has much less effects on the risk of disability progression. Why? Because now we have shifted to the degenerative phase of the disease. This is clear, this is true. And when we look at the contribution of MRI, we see exactly the same thing. What happens is that if you, at the onset of the disease, if you have many lesions in the brain, then the risk of a much more rapid evolution for the progression is much higher. And also, if you look longitudinally, you see that are the lesions that are accumulated in the first 5 years that play a major role in the accumulation of irreversible disability. So again, what happened at the beginning when the dominating activity are the wave of inflammation due to the acquired immunity is very relevant, but if with the evolution of the disease, less and less this type of inflammation has a role, and more what takes place is the degeneration. So then the key question becomes, at which time point during the evolution of the disease we have this irreversible point of disability accumulation? Typically, in the past, we have considered this point when the patient started to have a visible accumulation of disability in absence of attacks. But what is now happening, based on a lot of recent studies, seems to suggest that this is not the real truth. This is a first study published in 3 years ago by the San Francisco group. This was some interesting study because the study showed that in patients followed for 10 years, there was an accumulation of disability not only in patients who had attacks, but also in patients who did not have attacks. And then the conclusion was, well, probably the attacks doesn't matter so much. Probably the degeneration is there since the beginning. And then the attack is just an accident that has not so relevant role. Here you see the lines of accumulation of disability. In green is the accumulation in those without evidence of attacks and without evidence of disability progression. You see that the curve, they are not so different one from the other. I want to go a bit faster and not to say that. Then this paper happened is a paper that demonstrated that if you examine large group of patients, more than 30,000 patients, in clinical trials or in natural history studies, you can find a proportion of the patients that already in the early phase of the disease, in the relapsing phase of the disease, start to have an accumulation of disability which is independent from attacks, a bit suggesting that you may have this disability progression mechanism already operative in a very early phase of the disease. It is true that the proportion of patients with this condition was a small one, is the green compared to the entire group, but it is still relevant. It is about 4%, but it's still relevant. Of course, when the disease evolves in the progressive phase now, most of the patient has such an accumulation of disability independent from attacks. So many different other studies have confirmed that. This is a study coming, just published, where there was an evidence that patients followed in the first 10 years of disease had in about 4% of the cases this progression independent from relapse activity. So today, then the view is that probably MS is a disease where these two mechanisms, the acute inflammation driven by acquired immunity and the chronic inflammation driven by the innate immunity, they are largely overlapping. The real consequence is one, that as soon as we will have drug available to impact this chronic inflammation, this drug have to be used very early. Not as we think now that we treat progression late in the disease and we treat early in the disease with just pure anti-inflammatory treatments. So it is a bit a change of view, it's a bit a revolution. I will now accelerate in order to stay in time. So the third aspect that I would like to discuss with you is this revolution of the digital medicine. If you think about what we do every day, we visit the patient. Usually the visit may last half an hour. So in half an hour, we try to understand what happened to the patient in the last 6 months, 1 year. So we take a photograph like this in a very narrow window, pretending to have a quite extensive information about the life of the person in the previous long period of time. Is this really the best way to do? Well, it is a practical way. We cannot live with the patient. So it is absolutely logical that we use such an approach. But now we have the possibility with the revolution of these devices that we put in the bodies of the person to have a much more close look at what happened to the patient. This is just exactly to try to reproduce. This is our visit, and these are the different days of the previous 6 months, with some good days, some bad days. So, and we will try to extrapolate by 1 day, not 1 day, half an hour in 1 day, which was the entire activity before. So now if we are able to follow the changes much more close to the reality, having a continuous information about what happened to the patient, and then producing some average of the behavior, we will be much more close to the reality. There are a lot of possibilities to have such a very close look to what happened to the patient. Digital medicine offers us a lot of possibilities, from the classical smartphones to some type of devices that we can fix in the body of the person. Again, I want to be very short, but it is clear that if we use these devices, we can test at home the person with different functions. We can test upper limb function, we can test lower limb function, we can test cognitive functions, and we can repeat such an exercise as far as we want. And it is clear, this is just an example, that what we can pick up is really quite reliable, because it reproduces an objective evaluation of the person. So it's something that we can really use. The possibility now to use wearable devices to assist monitoring has been, for example, tested in a study that I coordinated in Europe, where we followed for about 600 patients for 2 years, every second. And then we tried to derive information about different cognitive and physical functions. Of course, I have no time to go in detail, but just to give you one data, the study showed, for example, that there was, over the 2 years, some deterioration of the function of the person, not only in those who had an objective demonstration based on the classical scale, EDSS, for example, but also in those without. Those patients that we will classify as stable, doing very well, they had some deterioration of the functions. So that's again something that is telling us that this type of information can be quite important. And now, last point, and approaching the end of my talk, that is treatment. So here there are 2 points that are really fundamental. The first point is, in all neurodegenerative diseases, we need to treat as early as possible. As early as possible means also today in the preclinical phase of the disease. As you know, we have ongoing in Alzheimer's disease, in MS. We have ongoing already some trials in preclinical phase of the disease, which is logical, because if we think at the results of what I've shown before, it is clear that the neurodegeneration is present very, very early, 15, 20 years before that we can pick up this condition by our visits and our exams. So we need to treat very early. There are a lot of evidences and reasons why this is fundamental, and this is really one of the fundamental points. And the fact that we can really need to treat as early as possible is coming from the results of a study that's presented a few months ago at ECTRIMS, where patients with preclinical MS, patients with radiologically isolated syndromes, only occasional pickup of some MRI damage without any clinical evidence, when these patients were randomized to receive a disease-modifying treatment or to go to the placebo, after a couple of years, it was clear that those who have been treated have a much lower risk of develop MS compared to those who receive placebo. So it's a treatment, incredible. So this is really the future, and more we will move in this direction. The second fundamental point is the personalized approach, what is today defined the personalized medicine. This type of possibility is based on a lot of advances at many different levels, technological levels, increase of knowledge. It is clear that because these diseases, neurodegenerative diseases, are so variable, we need to try to use appropriate tools to treat depending on the state of the disease. And this is, again, something very, very important. How can we do such a choice? Well, it's because we have predictive factors. We have factors that help us to predict which will be the evolution of the disease. So we can use an appropriate level of anti-inflammatory activity, which has to be based on the strength of the disease. So our strength of treatment should be adapted to the strength, individual strength of the disease. This is an example of the combination of factors that require such a possibility. And of course, we have a lot of different treatments. Look here, there is a tremendous amount of different treatments that we can use. And of course, we will never treat with a very aggressive therapy like alemtuzumab a person with some minor paresthesia in one leg with only a couple of small lesions, because we will overtreat and we will produce more damage than advantages, and vice versa. I cannot treat with beta interference a patient with 20 enhancing lesions with a lot of damage inside. So we should really be able to adapt the choice of treatment based on this type of condition. Things are even more complicated because, of course, we have to consider many other factors that has to do with the life of the person with the disease. For example, in MS, MS is a disease of a young female, so pregnancy is an expected possibility. So some of the treatments may have a negative impact on pregnancy. So we have to adapt our choice, also taking into consideration the impact on the person. And there are many other aspects like this. So to personalize means to take into consideration everything and have the person with MS on board in order to share the decision and then to do our best. Here, of course, again, we have the two opposite extremes. We can start with less aggressive therapy, and then when we fail, we can increase our strength going to a more active treatments. If we take such a strategy, we have to have in mind that we will fail in the vast majority of cases. So Vice versa, if we take the opposite view, that we start with a very aggressive therapy, we have to have in mind that we are facing a disease that lasts for 30, 40 years. So we have to think about how we can then continue to treat and how we can expose the patient at a very high risk for a long time. Again, that's a quite complicated story. So I think, as always in life, choices are not so easy. I can skip this. But it's clear that if we treat more aggressively, we give much more possibility to succeed to our intervention. So I think I can stop here and open to questions. Thank you so much for your attention.
So Professor Comi covered 了很多 pressing issue.
Thank you, Professor Comi, for showing us the very practical issues like the relation with a virus and progression, disease cause, and individualization, and the digital medicine, etc. So, any questions or any discussions? I'm not sure if we can collect some questions from the online platform.
By the EB link to MS. I don't know if you have mentioned that the EB virus is detected in the brain of the patients or only in the blood?
The EB virus is detected in the brain and particularly in the meninges. And usually it is detected inside cells, for clear inside B cells. And typically these B cells are in the depth of sulci. They are like the small lymph nodes. They are follicles of B cells. And one of the possibilities is that the virus is staying there and it may periodically reactivate, inducing an immune response. And it's the immune response that is responsible of the damage. That is one of the hypotheses.
What about in normal people?
No, in normal people, of course, that's a fundamental point. In normal people, it has been seen very occasionally and in a very small amount of cells. So there is a tremendous difference between normal people, no or one of two, and MS 100, just to give a number.
So it's the virus load. Is it possible it's the leakage of the brain to B cells that's causing MS patients have a higher load of the virus?
That's again a very difficult answer because there are no enough data to say that this is what happens or not. Well, as I said before, the first very simple possibility is the virus enters the body. The virus is usually initially in a very active phase, then it goes in a silent phase. It stays there might be forever, as it happens in most of us. But in some other people, the virus reactivates because of a deficiency of the immune control. And then the question is there any other virus that may interact? And there are some evidences that there is another virus that may interact, but then things are becoming a bit too complex.
One last question. If the virus load is correlated with the disease severity, could we just develop a kit like the COVID-19 antibody kit just to monitor everybody?
No, there's no evidences or not enough evidences that the viral load in the brain is related to the severity. And the reason is that such a study is very difficult because only post-mortem studies may allow you to explore because biopsies are not collecting enough tissue to estimate the presence and the load of the virus. So it is always a post-mortem, so no way really to come up with a correlation.
Yeah, need a surrogate.
我们的时间实际上稍微超过了，但是我还是愿意 allow more discussion.
Okay, we'd like to allow more discussion. So we hope that we can buy some time from tea break or from the afternoon.
And if anyone has, I'd like to talk about COVID. And I think the past 3 years has a really dramatic human experimentation that such huge population got infected. And so we don't know over the years if there is a prevalence of MS will increase on a global basis, or the patients who has MS will be exacerbated. Whereas COVID is like flu because we don't have much evidence linking flu to MS as we do with EBV. So, I mean, what's your prediction? And
Well, at least in the based on what we know today, we did a study, a large study, 2 large studies, looking at the interaction between the virus and MS. And in reality, we did not reveal an effect of the virus on the risk of disease reactivation. No, it was really not, in no one of the 2 studies this data emerged. There have been a couple of publications that suggested such a risk, but when we control for a very large population, we didn't see that. What is unknown, is too early to say, is if you may have a more long-term effect of the virus, and particularly for cognition in MS, that require a more long observation in order to know if some such interaction is there.
I think we could agree in that we should treat MS patients as early as possible, but how early? Because we can't identify individuals that, you know, very early stage of MS, subclinical stage, because they don't see neurologists. And many of the cases are sporadic, so it's not hereditary. Like we can identify early AD, but I think molecular medicine is really lacking for MS research and therapy because the lack of ability to identify early patients, that's a really challenge in my clinic, probably in yours as well.
No, I fully agree. I fully agree. There have been a lot of attempts to find a marker that describe the condition of MS in the preclinical phase, but as far as I know, at least until yesterday, no one really succeeded. So at the present, probably the best marker is an elevation of neurofilaments, but it is very specific because it can be also related to other causes. So we need really a specific biomarker that is really telling us that's really a problem. And this is very important, by the way, because the result of the clinical trial in preclinical MS is clearly there to show that if you treat very early, you have a quite strong effect. In this study, the risk of disease was reduced by 82%. And the drug use was not a very powerful treatment. It was a good treatment, teriflunomide, dimethyl fumarate, but not like the monoclonal anti-B. So it is clear that if you treat very early, you have a much more effective treatment than if you use the same drug 5 years later.
Right. Absolutely. Yeah. Just one last question.
Thank you, Professor Comi. My question is that since the EBV virus infection in 90% in all population, but it seems that the MS patient and its population is not that large as a incidence of EBV infection. So my question is, what are the driving force do you think in these patients infected with EB virus and drive them to MS, except besides for the mononucleosis and antigen mimicry as you presented? And another question is that we know that many people are tested for several positive for antibodies anti-EB virus. So, do we have any like suggestions for these people? So how to prevent like disease like MS?
Yeah, let's start with the second question. The problem is that because you have 95% of the patients positive, even if you come up with the test positivity, you have to treat 1,000 patients to have one having an advantage in terms of prevention of MS. Let's imagine that you have a drug that is able to prevent MS, and you treat all patients who are positive, so 95% of the population. You will expose a large population to some adverse effects risk, because you cannot exclude that the vaccination, for example, may not result in some negative adverse effects. So that's the point. The only way to use the antibody test in MS is at the diagnostic time. If a person is negative for the Epstein-Barr virus, EBNA negative, for example, it is not possible that the person is an MS. Or, if you like, it is almost impossible. So we use this in some cases where it is very difficult to come up with a differential diagnosis with other anti-inflammatory disorders. Then we use the test, because if the test is negative, we say, okay, it cannot be MS. But this is the only way we can use today the type of investigation. I did not really fully understand your first point. Are you talking about?
So a small percentage of individuals who infected with EBV develop MS. So what's the difference between those who didn't develop MS?
Okay, no, that's exactly the key point. Well, of course, as I showed, is not, of course, enough to be positive. You must have at the same time HLA B15, for example. You should not have other risk factors, for example, smoking, sun exposure. All these play a role altogether. Having said that, it explains only 1/3 of the variability. 2/3 are still unknown. So some other factors that have to be environmental, because genetic studies fail to reveal any prognostic factor. So it has to be environmental, but what?
I don't know.
Don't know.
All right.
Okay.
Thank you so much for the very...
I have just a quick question, please.
The last one, all right.
Thank you, Professor Comi. First of all, I would like to express our warm welcome for you to come to China. We were honored to receive you back in 2018, and we are so thrilled to see you again in person, finally, after 5 years. So today, my question is really regarding the epi data in different populations. For example, we see that in the Caucasians, the prevalence of the MS is much higher. It's like 40, 50 times higher versus the Asian population. But in terms of, for example, the EBV infection rate, seems there's not a differentiating factors. So what is your perspective in terms of how to explain the difference across different population, different cohort among Asian versus Caucasian? Thank you.
Thank you. Again, that's another very interesting point, no doubt about that. So, of course, as I said, we have 1,000 people positive. In Europe, only one will become MS. In China, only 1 out of 100,000 will become MS. Why? Well, because I think genetic factors have a role in this predisposition. We know that HLA system, for example, has a different type of combination in terms of risk for MS here in China compared to Caucasian, for example. But the second factor is, of course, environment. Why we had such an increase of MS cases in Europe in the last 100 years? Why we had, at the beginning of the last century, the ratio of male females was 1:1, and now it's approaching 1:3. In 2-3 generations, you don't change genetic factors. So you have a strong influence, if you multiply by 3 in 100 years, of environmental factors. One is smoke, no doubt about that. In Europe, there was an explosion of smoke in females, and this was, for sure, is one of the causes of this. But other factors are still unknown. So my answer is, again, is because of this complexity of combinations that you may come up with different results in different type of population. In black, for example, the genetic factors that predispose to MS are different, are also different. And also the type of presentation is different. So again, environment creates a lot of variability. Last point, when you have a multi-family members affected by MS, there is a lot of variability from one person to another. One has a very severe form, and the monozygotic twins are much less severe. So again, why? Well, environmental factors.
All right. Thank you. Thank you. I think, so please, 这个对话会进行 continue.
We will continue the conversation for 1 day, so we will have to move on. And if you have any further questions, we will have the ECF meeting in November.
It's later for November, so you're encouraged to join. And we also have joint programs. So we have plan, we have conversation yesterday to prolong the program. Anyway, 下面, so please introduce the second speaker.
Yeah. It is my really great pleasure to introduce the second speaker. The reason I'm so pleased is because I had already the opportunity to meet Dr. Chao Zhang, who is attending a neurologist at the Department of Neurology at the Tianjin Medical University School, deeply involved already in area of research in neuroinflammation in different diseases. And his talk today will concentrate on the animal spectrum disorder. Animal spectrum disorder is really becoming an extremely interesting disease for many different reasons, and his talk will be in NMOSD for molecular profiling to therapy. Please.
Thank you very much, Professor Comi, for your kind introduction. Professor Comi, for Professor Shi, Professor Laconi, Professor Chen, dear colleagues, good morning, everyone. I am from Tianjin Medical University General Hospital, Neurology Department. I am Zhang Chao. Today, I'm very delighted to be invited by Prada Foundation to be here and share with you. So today, I'm going to talk about NMOSD. Of course, right now, we usually believe MS or NMOSD in terms of pathophysiology, and also for long-term patient management, we usually consider NMOSD to be a neurodegenerative disease. So in the textbook of China for the disease pathophysiology, we still need to explore more for NMOSD. So today I'm going to talk about from molecular profiling to therapy. How do we get a better understanding of NMOSD? Of course, for this topic, this is a very broad topic, and for the current understanding of NMOSD, I would like to start with the current understanding of NMOSD. Different from MS, we believe NMOSD is still B-cell mediated humoral immunological disorder. So right now, we believe for NMOSD, it starts with the peripheral T-cell, B-cell, especially B-cell in the peripheral. After T-cell being activated, it will differentiate to plasma cell and then generate disease-specific AQP4 autoantibody. So apart from interaction of cells, there are a lot of other factors, for example, IL-6. And for AQP4 antibody, after it's been generated, we believe it's mostly being generated in the peripheral. So in the CSF and peripheral blood, if you measure the titer, we will notice much higher antibody titer for AQP4 in the peripheral blood. So it's a pathogenic antibody, and also it's a specific for NMOSD. After entering into China, firstly, it will target the AQP4 antigen on astrocyte, and it will also activate the complement cascade reaction. So astrocyte and microglia cell will be activated. For the pathological reaction, will happen in the damage of astrocyte, and the neuron will be damaged, and we will see myelin sheath loss. So for MNO, SD, different from MS, I think firstly we will have, of course, different name, and also we have the LETM. So LETM in terms of a clinical implication, basically attack is more severe than the clinical manifestation of MS. And also for the optical neuritis, once the patient had optical neuritis, they will have acute and severe vision loss. So for the LETM and also for optical neuritis, basically it will have a lot of disability impact, and with each attack, the clinical manifestation or clinical impact is not reversible, at least cannot be reversed to baseline. So for NMOSD, basically the impact is mostly from the attack of the optic neuritis, etc., and also the LETM. Sometimes they can both happen at the same time. We said that NMOSD is mediated by B-cell abnormal development. So how did it happen? Because for AQP4 antigen, it's expressed in a lot of organs in the system. Why? It's mainly attacking the CNS. So far, we believe that NMOSD patients, for the B-cell immunological abnormality, it mostly happened in two parts. The first part is in the CNS, and the other part is in the peripheral blood. So there is a defective counter-selection of cell-selective B-cell, so the immune tolerance has been damaged. Therefore, we have the AQP4 autoantibody being generated. Of course, throughout this process, there's a lot of interactions between T cells and B cells, high-frequency mutations, etc., or hypermutations. So these are the current understanding. But now, a lot of studies identified that B cells in the peripheral may interact or enter into the brain. So for the B cells in the meningeal, whether it's also involved in the immune tolerance. So far, we have evidence to demonstrate that in the MS. However, for NMO, do we also have this mechanism involved? I believe we need further studies to validate that. This is a slide from Professor Comi. So here, this is for the B-cell lineage from the stem cell to the plasma cell. The overall development of B-cell in terms of the expression of very classical markers, we can see that start from pro-B cell to the early antibody producing cell, and also for the relevant antibodies, we can see that it's narrower than the CD19. Of course, we have different IgD, IgM expression. All of these suggest that throughout the maturization and differentiation process of the B cell, different stage of B cell is involved. And here I have added the transitional B cell because it's not included in the original picture. So the transitional B cell connects the bone marrow and the peripheral blood and the peripheral immunological organ. So in this stage, the immune tolerance may easily break in this stage. That's why I add transitional B cell as well. In some studies, it's being included in the early naive B cell development, but actually it's an immature naive B cell. And for CD38 molecule, it's very special. In the pro-B, pre-B, and transitional B cell, we do have this expression. However, for the activated and for the memory B cell, it's not expressed. However, for the plasmablast and plasma cell, CD38 has an expression again. So for long-lived plasma cell in particular, it will eventually go back to the bone marrow. And this may drive the inability of autoantibody clearance. So in clinical practice, we do have a lot of anti-CD20, anti-CD19 therapies to treat the relapse of NMOSD. However, daratumumab as a CD38 deletion agent, whether it will be able to treat NMOSD, we still need clinical validation. And for plasma cell specific inhibitor bortezomib, in the previous report, it's already been reported. So for plasma cell deletion therapy, bortezomib may have some specificity because we think that for the autoantibody producing cell, it's mostly the more matured stage of the B cells. So we had a lot of B cell deleters. We have anti-CD38, and also we have a lot of agents targeting the plasma cells. However, these are non-specific. So what kind of cells can really producing AQP4 autoantibody? And also how many these cells we have, and how do we identify these cells? I think that in NMOSD, if we want to have more precise treatment, that's something we need to explore. So for NMOSD patients, we have collected their bone marrow, CSF, and peripheral blood B cell samples, and after sorting, we have done some sequencing, stem cell sequencing, and with high throughput transcriptome sequencing, we have compared in these three different issues the distribution characteristics of B cells and also the subtype of B cells. In general, NMOSD patients, comparing to what we've known before, in patients CSF, we've noticed that there is a memory B cell and plasma cell proportion increase. This suggests that in the CNS, there's obvious clonal B cell activation. In the bone marrow, we have a lot of antibody secreting cells comparing to healthy control. So for B cell, we have done some categorization as well. According to some very classical markers, we have categorized them into naive B cell, memory B cell, and antibody producing cell, and age-related B cell. For these cells, they have different markers. And throughout the B cell development stage, we've noticed that there is a continuous process, and in between cells, we have seen there's cell differentiation. And for AQP4 autoantibody producing cell, it's mostly being produced by plasmablast. However, for B cell development stage, because BCR will be expressed on the surface of B cell and will stimulated by different external factors. For some of the naive B cells, there might be hypermutations, so their BCR may be more likely to have AQP4 autoantibody production function as well. So even though we have deleted all the plasmablast, we still have some patients that can also produce AQP4 autoantibody. So targeting plasmablast alone may not be able to completely clear AQP4 autoantibody. However, if you delete all B cell and plasmablast, then for B cell deprivation, B cell depletion, then under COVID-19, vaccination, etc., will be a challenge. So for next stage of our work, our focus will be on the B cells. What are the abnormal inflammatory response stage, and what kind of B cells are the specific B cells we need to target. Via stem cell sequencing, we've noticed that for the autoantibody producing cell, we believe it's the CD19 positive short-lived plasma cell, SLPC, and plasmablast. However, from the development stage of plasmablast, we've noticed that we still have some CD19 negative LLPC and also very special plasma cell that can express or not express CD138. So to have such a detailed categorization is because we have the anti-CD19 monoclonal antibody compared to anti-CD20 has a much broader spectrum of depleting CD19. So you will be able to deplete SLPC. However, for some of the plasmablast cannot be cleared by anti-CD19 antibody. A lot of these cells are long-lived plasma cells in the bone marrow.
So anti-CD19 monoclonal antibody is a very powerful drug to reduce the recurrence. However, in terms of the seroconversion, that's different. The seroconversion rate is not reduced so well to be a negative. So that indicates that the long-term survival of plasma cells or the antibodies in the bone marrow is a very important reason. So we just talked about B cell and plasma cell, the biomarkers, the development process. But what's more important is that in which stage the B cells will be abnormal. So will those abnormal reactions be the targets of the B cell depleting therapy? So you can see that we have done a functional study on the B cells. So for the NMOSD, CSF, and the peripheral blood, you can see that there is an overactivation of the interferon pathways. So beta and gamma interferons are highly activated. So on the right side, you can see that we have summarized 146 important interferon signatures. You can see that in the CSF and in the peripheral blood, a lot of molecules are highly expressed, upregulated. So these targets may be a very important target for the B cell depleting procedure. So here you can see that this is the big picture of the B cell. So you can see that for this disease, B cell function is a kind of a pro-inflammatory. So you can see B cell can express very important chemo factors like the CXCR3 and the 4 to recruit more cells, and also in the brain there are a lot of B cell associated events. For example, the inflammatory reactions associated with the differentiation and activation of a B cell in the brain. So we have found a new monoclonal antibody. So it is approved for lupus treatment, and in NMOSD by blocking the type 1 interferon pathway you can see that the molecular antibody anifrolumab can inhibit the inflammatory reactions, and we are doing some explorations from this regard. And also, there are a lot of important kinase system associated with the type 1 interferon pathway like JAK1 or TYK2, so that the nucleus will be activated. We know that there is a very important molecule which is STING. The STING pathway will be activated. It is a very good marker or symbol to reflect the active from the interferon pathway as a response to the bacteria or virus infection. So we will talk about STING pathway as well. So in the initial stage of a B cell activation, you can see that the BCR signal, the translation is a very important stage in the disease. So a very important molecule in the BCR signal pathway, including some membrane factors, CD79 and blank and other molecules. You can see that we had a study to compare the molecules from the patient and the molecules from the normal control. So you can see that for the NMOSD patient in the peripheral blood, you can see that there is some downregulation of a lin, which is a kinase, and on the right side you can see some of the factors or molecules associated with the interferon pathway are activated. And LYN, so this is kinase. This is a kinase, and it's a kind of downregulator of the B cell function. So it plays a very important role in regulating or negatively regulate the B cell activity in the peripheral blood. So you can see SYK or BDK. You can see that these kind of kinase are activated as well. So from the membrane to the cytoplasm, these kinases are not balanced anymore. So we have done PCR, and also we did evaluation of the protein expression level for those molecules. So you can see that the BTK and its activation form, that is a phosphated BTK, has a high expression. And also we compared the B cell in the CSF versus B cell in the peripheral blood. You can see the similar trend. So for the NMOSD, the BTK and also the functional BTK, which is a phosphated BTK, are with a high expression. And also the BTK inhibitor, brutinib, by treating the B cell with the BTK inhibitor, you can see that these kind of molecules will be inhibited. So the BTK inhibitor has been widely used for treating B-cell lymphoma, and for NMOSD, other types of a BTK inhibitor may be useful, and we need to do more evaluation in the clinical practice. So apart from the BTK, in the B cell, BTK can be also expressed in the peripheral cells. For example, BTK can be expressed in the small glioma cells, and also you can see that it is highly expressed in the glial cells. So not only BTK but also the activated form, which is a phosphated BTK. And also in the animal study, the BTK inhibitor can inhibit the activation of the B cell. So BTK inhibitor can target the peripheral B cell, but also it can target at the small glial cells in the brain. So it has two roles. So I think that it has a similar mechanism as the currently available BTK inhibitors. So this is a very brief figure. You can see that by treating the B cells with zanubrutinib, we can inhibit the B cell, and there are two tasks. Firstly, we need to have some drug which can have a BBB permeability to target the brain, and also for the MS or NMOSD, for the very early patients, with the long-term use of the antibody like anti-CD20 or CD19, there may be a lot of issues associated with the monoclonal antibody. However, the BTK inhibitor may become a very important sequential treatment following a long-term use of a monoclonal antibody, so that we can prevent the patient from progressing. I think that we need to have a more clinical validation. Apart from the B cells, the B cells do not solely exist. So B cells need to talk to T cell. There are a lot of crosstalks between the different immune cells. So that's why we can have just like a panoramic view for the lymph cells. So on top of the B cell testing, we can do the further subtyping for the lymph cells. So you can see that apart from the B cells in the NMOSD, other immune cells are also imbalanced in the proportion. So the next step, we will have a lot of studies into the NMOSD cases. So a very important finding is that we can see that through this study, you can see that there are a lot of molecules as a response to the immune reaction, for example, bacteria or virus infection. These kind of molecules will be upregulated. So we can establish a Th17 induced NNO model in AQP4 double knockout mouse. So we want to see what's the role of the sting. You can see that by knocking out sting, we can inhibit the production of a C1q from the small glial cells. So this animal model of NNO is different from the previous BTK1 inhibitor mice model. So this mice model can have better simulation of the peripheral the T cell activation, and also to mimic or to simulate the breakthrough of the B cells. Every model has its own characteristics. So this model can reflect the immune status better. However, for NMO, there is no such thing like a EAE or AD. We don't have well-established model. So I think that in the future for NMO, we need to do more development in the animal models. And finally, I'd like to show you two slides to talk about the treatment. we had just a review that we can do high throughput testing from the B cell or from the paranomic view of the lymph cells. We can find out some targets as the exploration for the future. So to the date, in the NNO, in the FDA or CFDA approved targets, you can see that CD19 and also the IL-6 and also the C5 inhibitors. So these are the preventive targets. And internationally, you can see that under the leadership of Professor Shi Fudong, we are trying the current available drugs like rituximab and the toxilumab, the IL-6 inhibitor, and also the bertozumab, the plasma cell inhibitor. So we can use those kind of drugs. So actually, the pathway are very similar to the satralizumab or eculizumab. However, eculizumab is not available in China yet. So in these targets, we can do a lot of clinical explorations. I just mentioned a lot of issues of the drugs, like JAK1 inhibitors or the BTK1. So if those kind of drugs can be used in the long term in NMO, we should do more clinical studies. So the final of the final. So this is a final wrap-up of what we have covered today. So NMOSD actually is now treated by targeting the membrane molecules or membrane targets. For example, B cell depletion, like CD20 or CD19 depletion. So these are the currently available drugs to deplete the B cells. And now in China, we have some of the researchers doing studies on the BCMA, which is the final step of the B cell differentiation into plasma cells. They will use the CAR T cell to deplete the specific plasma cells. So it is based on the cell membrane molecules. And in the future, we are going to move from the cell depleting targets to non-cell depleting targets like the complementary inhibitors, and also the I just mentioned a couple of important drugs like BTK inhibitor and also the carriers inhibitors. So these are the non-B cell depleting drugs. We can slow down the progress and to prevent recurrence. So this is all I'd like to report for today. Thank you so much for your listening. Thank you.
Thank you so much. I think it was quite a comprehensive type of presentation on a very evolving area, quite evolving. I have to say, I want to start with the question. Is there any, you showed the role of the interferon receptor in the pathophysiology of NMOSD. Is there any data on the impact of interferon beta therapy on the NMOSD evolution?
Yeah.
Can you just elaborate a bit about that?
Yeah, it's a very good question. From clinical practice, we have found that interferon beta treatment can decrease the relapse rates of multiple sclerosis. However, to date, we haven't used interferon beta in Chinese patients. Present data have shown that interferon beta may increase the relapse risk of MSD that is very different from multiple sclerosis. So from these mechanisms, we we think like lupus, interferon receptor 1 may be a candidate target that can treat MOSD.
Thank you. Another question, you mentioned BTK. BTK inhibitors are becoming so interesting from many different points of view. What is your expectation about the effect of BTK inhibitors in NMOSD? You listed them among those who are very promising, but you personally, what do you think? Do you think that they will have the same efficacy profile compared to the monoclonal antibody, or it could be just to be used more as a maintenance therapy? What is your opinion?
Yes, thank you. I think BTK inhibitor is just a preclinical finding in B cell high throughput technique. BTK inhibitor may be helpful in inhibiting B cell activation, but also may penetrate into the brain through the BBB, like zanubrutinib, evobrutinib. It may also protect the brain by inhibiting the activation of microglia. So, like MS, I think in MOSD, BTK inhibitors may be a promising strategy that can act as a sequential treatment after